We'll actually do a recording of this session in case anybody needs it. And so where we are today is we basically started a program with Florida Orthopedic Institute basically to understand where we're going and what we're doing in orthopedics. And so we have seen in orthopedics a lot of complications in our cardiac database that we've had over the years of cardiac CT patients. And so we said, well, let's focus a database on orthopedics and see if we can understand these patients and how to pre-op them and what's happening to them in a cardiovascular wise in a orthopedic environment. We singled out hip and knee patients because those are the ones that seem to have the bone powder that appears in the right atrium and right ventricle during the procedure. We thought that is a unique platelet activator. So keeping that in mind, let's see what we can say today about cardio-orthopedics. So we thought we'd start with a patient and go from there. So here's a patient that's a 79-year-old lady who's very active until she had some problems with her hip. She's had left knee replacement with pulmonary emboli in the past at that time. So she seemed like a higher risk patient for us to be evaluating. So it seemed like we had a good focus. Of course she has a history of hypertension because it seems like a lot of people in this age group who are having orthopedic work done have hypertension. And but she doesn't have LVH, so that's kind of unusual. Her ejection fraction is 70%. She does have strain that's normal, and we have to sort of get you used to looking at something called echo strain that's made from spectral tracking imaging and seems to be ready for daily use in the clinic. So we've been using this for 4 years, and we started out with cardio-oncology, and this has been useful to us in evaluating patients with hypertension. And this tells us as much as that there's no LVH. It tells us as much as that does in terms of being good cardiac function. She's very active. At 79, you'll never think she's 79. You'd think she's 59 if you saw her. She's in real estate investments through banking. She's a ballroom dancer, Tai Chi, and actually leads the Tai Chi group. And so that's very interesting. So we thought coronary CT would be our standard as well as echocardiography and CIMT. And so let's see what we could find out about her. So this is our gold standard being cardiac CT. We're interested in looking at a lesion that we found in her LAD. So you can see she has what we would expect in someone her age, which coronary calcifications from being one and done on stuff that she had in her 40s and 50s, more 50s in females, 40s in males, and they get liquid plaques and they basically pave over them with bone, which is hydroxyapatite, and you get these little nodules with positive remodeling, and it keeps the channel open, and they seem to have very little meaning. They're very dense. They don't seem to be something that would erode. They don't seem something like that would fragment. But we did find downstream a little bit after a diagonal vessel, this area that looks like it's maybe a divergent area, not convergent, and it's short. It could be a little convergent divergence there. There is a little convergence and then divergence, and then what we see mostly here is the blue or the purple, which is fibrosis, and then there's a little bit of the red, and we can look over here and say, yeah, there's a narrowing, and it's a 76% diameter stenosis, 89% area, and then there's loosely organized, somewhat reticulated liquid lakes of lipid, and not very well organized, not the usual Hershey's Kiss one that we see that we think is more destructive, and really not very close to the lumen. And so I would define this in terms of the lipid lake as not being very important. And I don't see, in terms of looking at this in detail, we did not see an ulcer. And so reticulated, disorganized lipid lake, no plaque ulcer, and just a short convergent divergent double cone, which in terms of hemodynamics doesn't have a lot of meaning either. And then a necrotic core of 43%, and the length of the plaque is about 5 millimeters. So this really didn't have a lot of significance to me, and I felt like it was a low-risk lesion. We found another lesion in the first diagonal that's only a 39%, and this is also does not have a lot of necrotic core at the area of the stenosis and not much necrotic core at of the total plaque. And then we're looking at these segments and how they join when we make these pictures. This is step and shoot to keep low radiation. And so you can see this is a slice, this is a slice, this is a slice, this is a slice. And then no severe lesions. And the slice can cause artifacts, and we were showing the artifacts here. And so this is our strain echo, which we think is very important in terms of showing decreased blood supply in people. And this strain echo has to be compared to the CT myocardial perfusion image, which we don't have on this particular patient because it was step and shoot and wasn't a CT scan that took an image off of one heartbeat. And so we're looking at the risk and the plan on this patient, and we see that the Carlson score risk, which is looking for stuff like congestive heart failure, is very low. The Goldman criteria is very low. The Canadian score would be low. Our Tampa Bay risk score may be a little higher because, we do have no plaque ulcer. We do have some hypertension, but no LVH. We don't have any paroxysmal atrial fibrillation. We did not do a BNP. We didn't know highly sensitive troponin T. We're getting set up. And so in terms of patients who are going to get activated platelets and patients who are going to go to surgery, that are having hip, we think that the most important thing is the plaque ulcer. And so we've got some convergent divergent double cone. Maybe we rate that as a 2, and we got a lipid lake, not well organized. So that might be rated as a 1 or a 2. And then the diameter stenosis, you saw what that was in the 76%. And so it doesn't look so bad here. Turia, any comments you'd like to make at looking at this plaque? There's our plaque, and there's our other plaque. So with no comments on the plaque, we are going to decide that this patient is low risk. And so what we decided we would do is we will send her to surgery, but we will navigate her. And she does have a history, let's go back, of what used to be the number one problem in patients having hips or knees, which was pulmonary emboli. So she had that and had a workup for coagulopathy, and nothing was found. So she does have some risk from that, and there are various regimens you can use for pulmonary emboli. And the regimen that we hit on was to use the Lovenox for 30 days post-op, which she had some
Code book 202 bed 1, code book 202 bed 1, code book 202 bed 1.
See, that's hospital, so we're going to mute you, Turia, because of the hospital background. And so we see basically on this patient that we're going to minimize the effect of the pulmonary emboli, and we're going to navigate her with a nurse to keep an eye on her. We don't have the ability to do the post-op highly sensitive troponin T by Roche 5th generation Cobus platform, but we're setting that up now, and we'll be doing that, finding out what the troponin T is after surgery and before surgery. So that's going to be useful on navigating patients. And so basically the bottom line on this patient is she did fine. And these lesions apparently did not cause any demonstrable problems. I will be seeing her in follow-up, and we were right that her risk is contained currently based on this not being high risk for orthopedic surgery. That's not to say this wouldn't be high risk for other surgery, but for orthopedic surgery, it does not have what we see as the magic formula, which is activated platelets plus plaque ulcer plus the rest of these findings. And so I wanted to share that with you. And let's go on and talk about what we're doing and where we're going. So this is our team, and this is the orthopedic group. And let's go and look at what our database is showing us now. And so I'll get you up to date on our database, which, as you know, there are 2 pages of guidelines on cardiovascular complications of the AAOS, as opposed to 183 pages of guidelines for DVT. So it's not very clear what people should be doing in patients with known coronary disease or history of cardiovascular events. They're recognizing, yes, there is an acute MI rate that is higher, 25 times what you would expect for hip replacement, and for knee, it's about 31-fold. And so they seem to be recognizing that there's a cardiovascular problem, but the guidelines fall far short in terms of giving us some advice on how to proceed. We think that the bone powder is a significant factor, and so we're monitoring for that, and at some point we'll be monitoring BTG. So let's go look at our database and see where we are now in our database. So I'll take you up to the database, so just hang on here. And this is what we refer to when we talk about plaque ulcers. And here's an ulcer that's 1.2 by 1.8 and a plaque that's pretty well defined. And these are amorphous, and this is a broad ulcer without a discrete neck, and then we're getting into an ulcer with a neck. And this is a stenotic with a discrete ulcer, and this is a well-organized ulcer with a neck. So we're trying to classify the ulcers, and here's a plaque ulcer to show you what it looks like. And this is information that the guidelines do not recommend doing stents in these patients for the most part, and they feel that hip and knee is considered intermediate risk. And so prophylactic revascularization is not recommended. And so let's go down here and see what our database is showing. This is our pilot project, and basically before patients are bundled, we have the capability of doing echocardiography, echo strain, carotid artery evaluation, and coronary CT. And then if we deem necessary to put a little device on for 1 week or 2 weeks or just a couple days, that's a Zio recorder, that people seem to adapt more freely to this than one of the boxes with the wires coming out. So we like this because of the ease. The only downside is it's not immediate transmission of the EKG. You mail it in, and then we read out the EKG afterwards. And then there's some delay, and that also causes a little problem too. So we're looking for atrial fibrillation as you know it, and feel that that's a risk factor that's important. We're also looking for left ventricular hypertrophy. We're looking for hypertension that's uncontrolled, as well as coronary artery disease. Our expense total for all testing and seeing the patient is $943, so we're trying to keep that down. And if we don't use a Zio, it's cheaper than that. We haven't added the NT-proBNP. We haven't added the highly sensitive troponin T, but we'll be adding that in the future. This is the sequence of observations that we make on each patient, and add the rhythm recorder if there's left ventricular hypertrophy, history of palpitations, history of atrial fib or flutter or fib ablation, or left atrial enlargement. And this is our standard reporting form that should be very useful to anesthesia and certainly to the PAs that are taking care of the patient post-op. And so this is one way of the form. Here's another way of displaying the same form. And we hope to make this available to anesthesia prior to every operation by the patient handing it to the anesthesiologist when they come in the room. So this is our cardiovascular risk bundle busters that we're concerned about. And we have a risk score that can be adjusted. And so it's a raw risk score, and then we have an attenuated risk score. And so none of the risk scores that I've seen so far are adjustable. And so we want to make ours adjustable so that we can make changes and lower the risk. That seems very logical. But the Charlson is not adjustable. The Goldman criteria are not adjustable. The Canadian are not adjustable. They're just historical events of diabetes, hypertension, previous cardiovascular disease, and so forth. And so this is the Rosetta Stone for us, which is the key to patients in decades of life and what's happening inside with the genes, the lipid pool, inflammation, arterial wall, the microbiota in the gut, macrophages, and then how we get into necrotic core and forming that red, low attenuation liquid lipid plaque that we call lipid lakes, how that is reversible at that point. And we've got cases to show you the reversibility, then how it leads to fibrofatty, then fibrosis, then calcified, and then goes into either stenosis or just random calcified plaques. They're not really random. They're usually where there's eddies and flow aberrations from arteries coming together or from branching of arterial areas or from different flow abnormalities. We see that this is our assessment. That's basically a standard dashboard that we put together to show where a certain patient is at this point. And the patient we showed did not have the plaque ulcer, so we did not think that she was at high risk. This is the normal that we like to see, and this is patients that have a CAD-RAS score that's low. The CAD-RAS score is scoring plaques and the presence of a plaque burden and looking at the highest degree obstruction and most complicated plaque, and then scoring according to that. If there's a stent, we add S. If there's a graft, we add G. And if there's a vulnerable plaque, we add V. And so that's our standard nomenclature. We're using the same thing on the carotids because there is an incidence of stroke post-hip and post-knee. So with carotids, we're scoring the same, except we're calling it carotid RADS, and scoring exactly the same as you score in coronary artery disease to make it equivalent. And so things that we do in supporting these patients is, one, we've got all the information, so we're able to say that if something happens to the patient in the hospital, they don't need to go through the routine cardiovascular evaluation, which usually consists of a chemical nuclear test and false positives, false negatives, and cardiac casts. And so we feel that we have enough information that that's totally unnecessary if there's a reason that a cardiologist gets called. We're interested in basically navigating those that have plaque ulcers, myocardium at risk. We're interested in anesthesia changes if there's severe coronary stenosis, if there's HOCM, if there's severe hypertension, if there's very thick ventricles, if the patient has moderate aortic stenosis, and so forth. And then what to do about paroxysmal atrial fibrillation and hopefully prevent it. And so it's been said, and we pulled this directly out of the literature, that there's an increase in cardiovascular disease, and it's skewed. Instead of being 20%, as if expected in this particular male population, from 60 to 79, it's 27 to 32%. So, and then in the female population, it's 9.7, and that's also increased. So this is information that's I'm not sure exactly how it's been gathered. This is a gathering of information post-op looking at troponin changes, and 1 out of 7 had a significant troponin change. I'm not sure what that's saying either, and so that's why we're doing our pilot project. And so if 1 out of 7 have some kind of myocardial injury, let's see if we can find out what that means. So exclusion from CTA in our database consists of chronic kidney disease with GFR less than 50 and chronic atrial fibrillation. We can't really do good coronary CT with that. Severe contrast allergic reactions. Recent cardiac cath negates the real need for doing a coronary CT. Recent CTTA means we don't need to do it also. Patient declines the test for whatever reason, irregular heart rhythm other than chronic atrial fibrillation, and the heart rate is too fast and the drugs are unsuccessful in lowering the heart rate. So these are our interventions and what we've found in terms of observations on our patients. So we've color-coded this to make it more observable rapidly so that you can assess just by looking what's going on in this group of patients. So the green means green light. There's CAD-RAD scores that are less than 3, or there are CAD-RAD scores that may be greater than 3, but the patient has a stent or has had bypass surgery. And so basically, and the bypasses are patent and the stents are patent. So that gives you the green light to proceed ahead. There is a red light in paroxysmal atrial fibrillation or chronic atrial fibrillation, and so that's a warning that we have complications from that, and we want to avoid them. Some of the complications may even be the treatment by the physician where he's giving blood thinner and they're bleeding into their hip or their knee. And then hypertension is extremely important, especially accompanied by LVH. And so if hypertension gets out of control, that can be an important contributor to a troponin elevation post-operatively. And left ventricular hypertrophy with hypertension, with hypotension, or with extreme hypertension can obviously contribute troponin from the subendocardium not getting adequate blood supply, not from coronary artery disease, but from the left ventricle outgrowing its blood supply by hypertrophy. And then, so LVH is very important. So we got the really important things here, and that's what we started with. And then we ran across a couple more important ones, and that turned out to be, we were looking and found some left ventricular, we found some aortic aneurysms. And so here's a thoracic ascending aortic aneurysm. So we thought that's pretty interesting. Let's put that in and give a new color code of a deep gray. And then look, we found another one and another one here. So we thought that would be important to start adding to our coding since we found 3 of them, and they were serendipitously picked up. Now, we did have one patient that said that her mother had knee surgery and ruptured an aortic aneurysm post-operatively, which was an abdominal aortic aneurysm. So we said, oh, okay, well, maybe that is important, and let's keep looking for that and looking at that. So that's an added bonus. And so the yellow means that we made some either new observation that's important or that we made some intervention that we considered important. And so, so let's look at our tabulation. So now we're up to 66 cases, and we'll probably add another 10 next week. And so we should be pretty close to 100 cases by July, which we intend for publication and for lengthy discussion. And of course, a presentation somewhere. So we have a total of 66 patients now in our group, and of those, about 60% of patients have hypertension, either diagnosed by having an actual history of hypertension and being on antihypertensive medications, or diagnosed by us by the fact that they have left ventricular hypertrophy that's unexplained. And so, as you can see, we picked up 5 cases of hypertension that was undiagnosed and put them under treatment. We have LVH occurred in 42% of all patients and 71% of hypertensive patients, which shows you that the patients are not being adequately treated for their hypertension. Well, how is that? Well, we see they're on either one, for the most part, one antihypertensive medications or perhaps two. We don't find very many that have crossed the threshold into three antihypertensive medications. These patients are highly sedentary because of their hip or knee, and some of them have gained quite a bit of weight, and so these factors may all be contributing to their hypertension becoming worse. And it seems like before they make the decision to go to surgery, they've been treated for a couple years, with either steroid injection into the knee or stem cells into the knee or some other therapeutic modality, and of course NSAIDs for a long time. And so they're a unique population. You might say, well, they've all got inflammation, but I'm not sure about how much inflammation, even though they have osteoarthritis. These are not the rheumatoid arthritis, or we have a couple of those, but that's not predominantly that. It seems like most of them are on very heavy doses of anti-inflammatory drugs. And so I don't know how that affects their underlying coronary plaque deposition. So that's interesting. So looking at our group, this is the most interesting thing, is the green light is in 98% of patients. So that means that they either have stents that are patent, they either have bypasses that are patent, or they have coronary artery disease that's 0 to 2. Well, that certainly upsets the apple cart, especially since all the literature is saying these patients have a high incidence of coronary artery disease. Well, maybe there is a high incidence, but there's not a high incidence of severe or significant coronary artery disease. So this is contrary to popular belief. And I don't think anybody has done a study like this going actually forward and evaluating every patient that's coming across the board that's being sent to them. Now, I know there is some probably preferential sending of patients to me for evaluation, but that would actually give it the bias in the other direction, and you would expect them to have more coronary artery disease, and they don't have much at all. So this is very interesting. They have coronary artery disease, they have coronary plaque, but they don't have significant lesions. And so then we came out with, looking at those, there was only one patient who had a chronic total occlusion who'd already been discovered to have coronary artery disease, and someone cherry-picked the plaques and put stents in the plaques that they were easily stentable, but the plaque that was the greatest, which was totally occluded, the CATO, they didn't tackle that one, and that was the ischemic area. So that was kind of interesting. He did go to surgery because I deemed him a good surgical candidate, and he did quite well with the surgery and is doing well in his recovery. And then new thoracic aortic aneurysms or abdominal aortic aneurysms, 3 out of 66, which is 4%. The cascade that we frequently see is hypertension, left ventricular hypertrophy, diastolic dysfunction, left atrial enlargement, left atrial fibrosis, paroxysmal atrial fibrillation, chronic atrial fibrillation, cerebral vascular accidents. And so that's one of the cascades that we may be witnessing here, which is kind of interesting. We didn't do CT on those, obviously, who had chronic atrial fibrillation, iodine allergy, increased creatinine, or who had calcium. And we did, if they had increased creatinine, we did a calcium score. So this is looking at our dashboard and distributing the amount of coronary artery disease according to the CAD-RAD score. And you can see of this group of patients, of which there were 66, of those 66 who successfully had coronary CTA, which the atrial fibs didn't, the chronic atrial fibs didn't have that, the iodine allergies didn't have that, and there were patients that just flat outright said, hey, I don't want the test. So on those patients, they're not included, but on the patients that are included that we have data, we had 18 patients that are normal, we have 27 patients that are CAD-RADs, 1 to 2. We have one patient that had the chronic total occlusion. We have 5 patients with patent grafts and stents. And then we always stick this one up here. It's not part of our study, but it's the one patient that we rescued from a cardiac event who had a CAD-RAD score that was high. And we're looking for these patients that have CAD-RAD score 3, 4, or 5 who've not been addressed. And the lady that I showed as our presentation case today would go into here. We haven't counted her yet because we haven't gotten up to her case yet in adding the data. So that sort of concludes where we are today in our analysis of patients with coronary artery disease. And it looks like, as the group in Poland saw, we have a lot more atrial fibrillation than they do. Perhaps it's an older group of patients that are getting their hips and knees. That we have a lot of hypertension, which is a big surprise, and we have a lot of LVH, and we have a lot of not well treated hypertension. This may be the source of the troponin that has been seen in 1 out of 7 patients, and we're going to be adding troponin, highly sensitive T, Roche Generation 5 Cobus platform very soon. We're setting that up now, and that'll be included in the database as we proceed forward. And then the big surprise is no significant coronary artery disease or very little significant coronary artery disease with either patent stents, patent grafts, or not much disease at all. And so that sort of concludes our overview today of what we wanted to share with you. So we can certainly ask if there's any questions from anybody at this time. And so I'm going to ask Professor Krosky if he has any comments he'd like to make, which he insists he's a student, not a professor, but we certainly are interested in his comments because he made the presentation last time. Dr. Krosky?
Well, that was, yeah, I can hear you. That was all very interesting what you just said, and I find it very interesting that, as you mentioned before, you use coronary CT for if you're looking for coronary artery disease, which in Poland is not a standard procedure, and maybe this is something to look forward in the future. So it's nice to see that you are implementing it, and also, again, this high prevalence of atrial fibrillation in your patients, so something to look at in our population that, as I mentioned before, you suggested or showed that this might also be a big problem. So lots of things to think about and to work with in the future. So thank you very much for this presentation.
Yeah, we appreciate your comments, and we're sorry that Sebastian couldn't attend, who's very interested in co-developing this concept in Poland and Europe. And perhaps Dr. Krosky can recruit some of his other colleagues to join us, because I know the Poland group there has been really looking at the patients in terms of cardio-orthopedics, and they actually used the term cardio-orthopedics in a paper that they published looking at a group of the orthopedic patients and asking the question, what should we do in terms of cardiac evaluation? Would you like to tell us about how that interest developed, Dr. Krosky?
Well, we are still at the very beginning of what we want to do. For now, we are evaluating and looking at the procedures, what can we improve while qualifying the patients for total joint alloplasty. So as I mentioned, for now, we have some data, a few hundred patients, and right now we are analyzing what we have, because we do make ABPM in our patients to look whether the control of the hypertension is proper. So we are still analyzing, so it's pretty early for me to tell you what we have found out, but we are hoping that this project will grow and grow. And as you mentioned, I hope that my colleagues will also join this meetings. So yeah, that is something that I'll tell them, and I'll encourage them to join to these meetings.
So do you have enough data that you could make a preliminary presentation next month to tell us a little bit about these 200 patients, at least in a sketchy way,
Uh, well, I can check. I can talk to my professor to check on where we are with analyzing the data. Let's make an agreement that I'll write you an email, okay? And then we will see how it all goes, because I'm not sure whether we will have enough time to prepare the presentation that will satisfy you and that I will be satisfied with, okay? So
Yes,
maybe I'll send you an email next week, maybe, let's say, okay?
that's great. But you have to realize that we're the only two groups in the cardiac world that are looking at this and showing any profound interest other than a retrospective chart review as they did in Mayo Clinic. There's no one that's going forward like your team and our team in this particular area. And there's no one who's ever used the term cardio-orthopedics except you guys and us.
Well, it's a great pleasure to be a part of this movement together with you. And as I mentioned, I will talk to my professor who's like the inventor of cardio orthopedics in Poland, and we will see what we can show you next month.
Well, that's very good. Well, thank you so much, and thank you everyone for attending. Brian, it's good to have you here. Daniel, I hope this will spur some interest in research in this area. Turia, we'll see you tonight when we do some update on our skills. Jarrett, thank you for attending. I appreciate that. Dennis, we'll be in conversations. And so this is where we are today in cardio-orthopedics on two groups across the Atlantic and here that are the only two that have done any prospective work in this field in the world. Thank you very much. Bye-bye.
Thank you. Bye.